He obtained his MD and PhD from the University of Naples and has completed a clinical research fellowship at the Institute of Cancer Research. Pasquale was also director of the translational and clinical trial team for GU cancers at Candiolo Cancer Institute, which is in Turin in Italy, and he currently serves as clinical senior lecturer and honorary consultant at Newcastle University and Newcastle Hospital. So we're absolutely delighted to have him on the call today. So without further ado, I'd just like to hand over to you, Pasquale.
Thank you, Ellen. Thank you for having me. It's my pleasure, and I'm a bit frightened to speak after Alistair Greystock and John Byrne, so I hope I can do a good job like they did. So just 2 seconds to share my slides. You should be able to see them. Can you please confirm?
Yeah, that's fine,
brilliant.
Pasquale. Yeah, that's great. Thank you.
So today we're going to discuss together one of the hot topic for whoever does prostate cancer, that is the relevance of homologous recombination defect. And we will discuss the impact from diagnosis to the treatment that this alteration have on prostate cancer. So just a reminder, just to have a refresher about biology. So what happens when there are double-strand breaks in the DNA? There is basically the activation of one of the high-fidelity mechanism of DNA repair, that is the homologous recombination mechanism of repair. It's a complex DNA repair pathway that involves a lot of protein. The first protein to be activated when there is a double-strand break is ATM. That is the protein that is known as a sensor protein that will basically sense the DNA damage and will block the cell cycle, and will activate the DNA repair. Other proteins that are particularly famous are BRCA1 and BRCA2, and that will be the one that will be discussed during the call today. But there are other relevant proteins like PALB2, RAD51, RAD52, so all the complex or RAD50 proteins. But while BRCA mutation, HRR alteration are known for whoever does ovarian cancer or breast cancer, the knowledge that these alterations are relevant in prostate cancer is quite a recent acquisition. We learned back in 2015, so not even 10 years ago, that almost 30% of metastatic, what is defined as metastatic castration-resistant prostate cancer, so the advanced prostate cancer that failed hormonal treatment, harbor HRR somatic alteration. And roughly 10% of these are of germline origin. But why these alterations are important for personal and familial risk of cancer, because can predict poor outcomes to standard of care therapies. So they have a prognostic relevance, but they are also predictive of response to new drugs like PARP inhibitors that have been recently approved in prostate cancer. So let's start from the beginning. Few weeks ago, John Byrne discussed about Lynch syndrome and the relevance of mismatch repair, but we know that there are syndromes that are related to germline alteration in BRCA1 and BRCA2 that involve several cancer. Ovarian and breast cancer are the ones that are known, but also prostate, pancreatic cancer, and melanoma. There are, though, retrospective study mainly from one of a dear friend, a colleague, Elena Castro, and her husband, David Olmos, from Madrid, showing that people that are germline carrier of BRCA alteration that then develop prostate cancer have a likelihood to present with a more aggressive cancer. So this has also a prognostic value. Mainly BRCA2 cancers, so patients with a BRCA2 germline mutation that develop prostate cancer present with a stage 4 cancer, and it's more likely to be metastatic. But we also know that germline BRCA carrier that develop prostate cancer and that then develop the metastatic castration-resistant prostate cancer have poorer outcomes on standard of care, mainly taxane and hormonal treatment. So differently from ovarian and breast cancer, where the majority of these alterations are germline alteration, in prostate is a bit the reverse. So the majority of these alterations are somatic, and almost half of them are of germline origin. And of course, I mean, everyone knows this, but it's just a refresh to refresh our memory. Somatic mutations are present only in the tumor, while germline mutations are present not only in the tumoral cells, but also in the normal cells. So this could have been passed and inherited by the offspring when someone is identified with a germline alteration and has prostate cancer. This, of course, doesn't have only an implication in terms of familial risk, but has also an implication in the way that we select and we identify this alteration. So if we only do germline testing, for example, we will miss all the majority of alterations that are somatic, and we will discuss a bit more in depth about this later on during the day. So why PARP inhibitors are relevant in patients that have HRR alteration, mainly in BRCA1 and BRCA2 alteration. So PARP is a protein that is activated when there is a single strand break into the DNA. And when there is the single strand break is not repaired, due to the administration of a PARP inhibitor, then the single strand break leads to a double strand break. In a normal cell that is HRR proficient, this is repaired and the cell is able to survive. While in patients that are in cancer cells that are HRR deficient, mainly BRCA1 or BRCA2 most likely altered cells, this leads to cell death or missed repair. So this is the concept of synthetic letalities, and is the reason for which PARP inhibitor have been developed as a drug for patients with HRR deficiency, mainly BRCA1 or BRCA2 mutant cancer in prostate cancer. So this is in theory, but the first trial that showed that the BRCA1 or BRCA2 altered, or more generally speaking, HRR altered cancers are sensitive to PARP inhibition was the TOPARP study. TOPARP study was one of the first, if not the first, biomarker select the trial that was selecting patients based on their biomarkers to show that olaparib in this case, so one of the PARP inhibitor that are available, was effective in metastatic CRPC. The part A of this study that is not shown in the slide basically was designed to offer PARP inhibitor to all comers, so to all patients with metastatic CRPC. And in this first part of the trial, what they saw was that the only patient with HRR alteration then responded to a PARP inhibitor. This led to the second part of this trial called TOPARP-B, where patients were selected beforehand based on their HRR status. 711 patients were screened within this trial, and everyone had a fresh biopsy of a metastatic site, including bone metastasis, prior to the start of the treatment. In this case, when and that's a concept that we will develop and we will talk about a bit later on during the discussion. But when we use, as in this case, a fresh biopsy, so within a month from the start of the treatment, the success rate for DNA extraction and reporting of a of an HRR alteration was 87%. Out of all the patients screened, 27% had an alteration in one of the protein involved in the DNA repair defect. Within this trial, there were not only patients were not only selected based on their HRR alteration, but more broadly on the protein that are involved in DNA repair. And out of these, then, 98 patients were randomized between two different doses of olaparib, 300 milligram twice a day, that is actually the standard dose for olaparib that has been approved, and 400 milligram dose. This trial showed that out of this nearly 30% of patients with DNA repair alteration, the majority of these alteration are BRCA1 or BRCA2. So 30% of these are BRCA1, BRCA2, 20% ATM alteration, 20% CDK12, 7% PALB2, and then 20% of other alteration, including RAD50, FUNC, and other alteration that are also relevant in other cancers. But olaparib and toparib are only one, let's say, of the trial that has tested PARP inhibitor in metastatic CRPC. We have other trials with other PARP inhibitors. Triton-2 tested rucaparib 600 milligram, and rucaparib is like a deer PARP inhibitor for Newcastle, because it was one of the PARP inhibitors that was developed in Newcastle for ovarian cancer. Galahad with niraparib, and Talapro one with talazoparib. All these PARP inhibitors work in prostate cancer, selected based on their biomarker, and as you can see, the overall response rate in BRCA1 and BRCA2 alteration is quite high, and nearly 50% of these patients respond to a PARP inhibitor when these alterations are present. However, the first phase 3 study that showed the efficacy, so that established the efficacy of a PARP inhibitor, was the PROFOUND study that tested olaparib in patients who progressed on a prior hormonal agent and had an HRR alteration. In this study, we had two different cohorts, cohort A that included BRCA1 or BRCA2 or ATM alteration, and cohort B for all the other HRR alteration. And patients were randomized 2-to-1 towards olaparib or a second hormonal treatment that could have been chosen by the physician. The primary endpoint of this study was the radiological progression-free survival, and in the cohort A, and second endpoints were the overall response rate, the radiological progression-free survival in cohort A plus B, and overall survival, and of course, safety and tolerability. So some of the results from this trial are really similar to the phase 2 study. So again, when selected, nearly a third, 27% is exactly the same proportion in the top that was shown in the TOPARP B study. 27% of metastatic castration-resistant prostate cancer harbor HRR alteration. Again, 30% of these alteration are in BRCA1 or BRCA2. 20% in ATM, CDK, and 20% in CDK12. So they are exactly the same proportion that were seen in the phase 2 study. But more importantly, this is a positive study. So patients that receive olaparib upon failure of an hormonal agent are likely to respond with a PFS of 7.39 months. That is the double of the PFS when the patient with this alteration receive a second-line hormonal agent with an alteration of 0.3. However, considering that this is quite a big trial, it also allowed some subgroup analysis and consideration. So definitely the group of the people that respond better to a PARP inhibitor are the one with BRCA1 or BRCA2 alteration, where the overall response rate is 43%, and 61% of the patients respond by PSA. But when we look at ATM alteration or CDK12 alteration, the proportion of patients that respond to a PARP inhibitor is really low. It's 10% for ATM and 5% for CDK12. And this is the reason for which in most countries, except for basically the States, but in Europe, in UK, a PARP inhibitor and specifically olaparib has been only approved for BRCA1 and BRCA2 alteration, not for the other HRR alteration. So at the moment, I'll stop here just to see if there is any questions, and then we will go ahead talking about sequencing and how we can define, how can we detect these alterations. So I stop the presentation here.
Fantastic, thanks Pasquale. So there hasn't been any questions so far in the chat. Does anybody want to raise their hands with any questions?
I think I probably convinced everyone that PARP
inhibitor
they work.
yeah, exactly. Yeah.
So we can go ahead to a bit more. Oh, there is.
Oh, we've got one there, Florentina.
Oh, nice name.
Hi, Pasquale. Thank you so much. I'm not Italian though.
Where are you from?
Italian. Originally from Romania.
Romania, all right.
Latin country as well. Anyway,
as well, so, yes.
Very nice presentation. Thank you so much. So I work in Sheffield in the hereditary cancer team. However, our team in Sheffield provides prostate cancer for the somatic side as well, testing. So there was a question raised by one of our colleagues if PARP inhibitors react differently to BRCA1 or BRCA2 variants with reduced penetrance. So we were wondering if that's the case, if you looked into more detail into these variants, or if you were supposed to present it in the next part, the type of variants that you included in your study. So I don't know if you could comment on that.
So it's really funny because I was discussing about this with Helen before starting the the call today. The penetrance is relevant, of course, for germline alteration. For somatic mutation, we are talking about pathogenic or not pathogenic. So if the alteration is pathogenic, I would say the cancer should be sensitive to a PARP inhibition. It's a different matters, in case of hereditary mutation, if then this alteration has an impact based on penetrance. And unfortunately on this, we don't have enough evidence yet to answer your question. So I guess that when we learn a bit more about testing in prostate cancer, we will also be able to understand if the penetrance, as I believe, has an impact on the response of PARP inhibitor in those patients that have germline alteration. The main concept, though, is that differently from BRCA, different from ovarian, as I said, and breast cancer at the beginning of the presentation, the majority of these alterations are somatic. So we probably should be focusing more on the impact of the alteration on the function of BRCA2. And again, this is another big deal. Because unfortunately, if a mutation is pathogenic or likely pathogenic because it's been described and it's been studied, that's easy. But there are a lot of mutations that are defined as variant of unknown significance. And I will bet that the more we learn, probably some of this mutation will be shifted towards likely pathogenic or definitely pathogenic, and other will be qualified as benign or not having an impact. So there is still a lot to do. And when you navigate websites that probably you are familiar with, like ClinVar or other websites where there are where we can find this data, and you really realize that some of this information are based on small trials or on small data sets. So definitely we need more. But now that testing and sequencing of prostate cancer has been is a reality, I would say the next 2 or 3 years probably we will have all the answer, and also the answer to your question.
Okay, thank you so much. Thank you. I appreciate it.
Thank you. So no other questions
Thank
yet,
you.
but please feel free just to put anything in the chat if anyone has got any. Thank you.
So I think I can keep going with the presentation.
Yeah, we can see that. That's great.
Brilliant. So I really like these slides because that's not mine, first of all. It's from a colleague called Rescigno that is a pathologist in Italy. But I quite like because it's really self-explanatory. So we have several ways to define and to identify this alteration. And one is through tissue testing, or we can use blood. In this case, we can opt for two different tests. One is the whole blood that will allow us to test the DNA present in the white blood cell. Or we can look at plasma ctDNA. So I'm not discussing a lot about plasma ctDNA because Ali Greystock did a brilliant presentation about that. But just to refresh a bit of the memory, this is basically the tests from the sequencing of the DNA that is the tumoral DNA that is free in our blood. So which are the main advantages and disadvantages of this technique and these tests? So definitely tissue testing is considered so far the gold standard. In prostate cancer, though, we have a huge problem that thankfully prostate cancer patients have sometimes really long oncological history, so they can relapse with metastatic disease years after their original diagnosis. So sometimes the archival tissue are really old. And the other problem is that, of course, there is tumor heterogeneity. Especially if we look at the archival from 10 years earlier, or if we take a biopsy of a metastatic site, we have no guarantee that 100% that will represent all the disease that is present in our patient. And again, there is a high failure of tissue testing, but we will see this in a moment. Using instead bloods, ctDNA testing will be, in theory, extremely easily because we can obtain samples anytime, and most of the time we can find ctDNA in our patients. However, prostate cancer is one of the cancers that might not shed a lot of ctDNA in the blood, so that could be quite an issue. And there are false positive. So sometimes we can detect alteration in genes like ATM or CHEK2 that actually are not tumoral mutation, but are basically alteration that are what they are called cheap. So that are basically alteration present in all the cells they age, including the white blood cell. And the other option is germline DNA testing. Again, easy to obtain because that could be done from blood, saliva, or buccal swabs, and this will allow us to assess familial risk. However, we will miss the majority of the BRCA1 and BRCA2 alteration in prostate cancer because, as I said, and as we know, the majority of these alterations are a somatic mutation, are not germline mutation. So let's go a bit more into depth about what I said just now. So tissue testing. The majority of these data come from the PROfound study, where there are thousands of thousands of samples. They tested more than 4,000 samples and screened them for the trial. The majority of these samples were archival samples, and only a minority were recently obtained samples. As you can see, when you use an archival sample, so a diagnostic sample that could be as old as 10 years or more, the success rate for sequencing is 56.9%, so really 57, meaning that 43% of the time these samples failed the quality control and we are not able to extract good DNA for sequencing. The success rate increases when we use a recently obtained sample, although compared to the TOPAR-B data that I showed before, within the PROFOUND study, recently obtained meant within a year, while in the TOPAR-B study, where the success rate was 87%, recently obtained meant within a month from the start of the treatment. So collection site is another issue. If we use primary prostate gland, the success rate can be low, but that's not because of the site itself, but more likely because the prostate gland biopsies or sample derived from prostatectomy are old samples. While if you use metastatic sites, the proportion of success rate is then definitely higher. The higher success rate is for lymph nodes or for trephine bone biopsy, while if you use a normal bone biopsy with standard decalcification, the success rate can be low. Again, age of sample. If we use a sample that is older than 10 years, the success rate is 47%. If we use a sample that is inverted comma young, so that has less than 1 year, the success rate is higher. Of course, the sequencing is also influenced by the tumor content and the DNA yield, and that's extremely important. So if we want to increase the chance of getting sequencing from tissue testing, we should use a recently obtained biopsy, more likely within a year or at least within 3 years. Use a metastatic deposit like a lymph nodal metastasis, using a sample that has at least 20% of tumor content and not going less than 20% of tumor content. Now, there is a huge, big debate in the field, and I guess that probably most of you are aware about this, about the use of bone biopsy. So there are a lot of people working in the sequencing space that still believe that it is not possible to derive good DNA from a bone biopsy. And this is true if we use strong decalcifier, that of course we will, like formic acid, that will destroy basically the DNA, making the chance to getting good DNA for sequencing almost zero. However, in recent years, there have been new development with new decalcifier, mainly containing ADTA, that are gentle decalcifier. Decalcification can last a bit longer, and is between 2 days or so 48 hours, or it could be even like 5 days, depending on the decalcifier that we use. However, this allow a preservation of the DNA, so good sequencing results. The other tips to use bone biopsy for sequencing purpose, and they're all described in this paper that I've recently authored with other colleagues, is to basically select the sites, the metastatic sites, the metastatic deposits, based on either MRI scan or CT scan, checking for the tissue that could be potentially more viable. And then, especially if we are using one of the site of preference for prostate cancer in terms of metastatic site, it is the iliac bone, we can use a quite big needle, as big as 8 gauge, to do this kind of biopsy. That will allow us to basically get enough tissue for sequencing as well. So we can use tissue coming from bone, but we need to be sure that we stick with these rules if we want to get good sequencing results from bone. Now, the main limitation instead of using the ctDNA is the kind of alteration that we are able to identify. So overall, there is a good concordance between tissue and ctDNA testing. And these are data again coming from Profound. In all the patients, so there are nearly 200 cases for which there were both tumor tissue and ctDNA available. There is a high concordance, but the highest concordance is for frameshift alteration, that are the purple one, or for the nonsense alteration, that are the red one. However, ctDNA, and that's for by definition, because the technique that we have available unfortunately do not allow in the majority of the cases a good copy number analysis. That means that we will miss the homozygous deletion. So we are not able to identify the majority of the time where we use ctDNA alone if there is a loss of the BRCA2 genes. And again, Ali Greystock did a great work last time talking about ctDNA and explained this problem extremely well. The other problem of using the ctDNA, it's a bit like the tumor content for the tissue testing, is to understand what is the tumor fraction within our sample, because of course the higher is the tumor fraction, the more likely is the chance that we get and we are able to identify biallelic deletion. Unfortunately though, for a tumor fraction that is higher than 10%, between 10 and 15%, we would be able to identify also biallelic deletion. However, the average tumor fraction in advanced prostate cancer is 7.5. So that will make really difficult any copy number identification or biallelic deletion identification in these samples. But why this is important? Why is this important? Why is important to identify homozygous loss in the BRCA gene? Because, and now we have clinical evidence about this. Patients with homozygous loss are the ones that are more likely to respond and respond longer to PARP inhibitors. So these are the data from the 2 phase 2 trial, the TOPARP with olaparib, the Triton 2 with rucaparib. And as you can see, so let's start from the bottom of the slide. They basically analyzed. This is a follow-up paper of the original TOPARP manuscript, and they went back and checked which kind of alteration the patient with BRCA1 and BRCA2 mutation had, and they then split the patient based on their alteration, if it was an homozygous loss, if it was germline mutation, if it was a somatic mutation that was not an HOMDEL. And as you can see, the patient having longer benefit in terms of progression-free survival or overall survival are the ones with the homozygous deletion. Triton 2 with rucaparib was basically a slightly different trial with a different PARP inhibitor, where patients were allowed, differently from TOPARP, were allowed to get a PARP inhibitor not just based on tissue testing, but also based on ctDNA testing or germline testing. So whatever was the testing done to identify the alteration, as long as there was a BRCA1 or BRCA2 alteration, the patient was deemed eligible for the trial. But as you can see from the forest plot, if we look at the overall response rate or PSA response rate, the one that have the most and the greatest benefit from PARP inhibitor are the one with homozygous loss, and are the one with the homozygous loss defined on tissue testing. The other problem, as we touched a bit this point during the question time, is that not all the alterations are the same. So definitely there are pathogenic alteration or likely pathogenic, and that should guarantee a response, potentially durable response to a PARP inhibitor. However, there are a lot of different variants of BRCA2 and BRCA1 alteration, and some of them are classified as uncertain, so are the variant of uncertain significance. So at the moment, this would be considered as not clinical actionable. However, my bet is that in few years, some of these variants will be probably classified as pathogenic when we have more evidence about this alteration, while others will be probably shift to the non-pathogenic, so likely benign or benign, and this should not guarantee or give any kind of sensitivity to a PARP inhibitor at all. And this is the demonstration, basically, that we are still at the beginning of our journey in terms of sequencing for prostate cancer. So this is a nice table with different international guidelines, so the European, the NCCN clinical practice guideline, the ESMO, so the European Society of Medical Oncology, the American Association of Urology, and the European Association of Urology, and the indication recommendation of which kind of test to use, or if we should go directly for germline testing or not, are slightly different according to the different cooperative groups. So as you know, in UK, we are divided in different genomic hub, and again, even within our own country, we have different rules about which kind of test we should use, and which kind of test we should use first. These are the recommendation of the GLH for the Northeast, and we basically came up with this rule based on the evidence from the PROfound trial. This is the work done with Ali Greystock, Paul Roberts, Rob Chandler, and all the other people that are part of the Northeast GLH. So our recommendation is always to start for a somatic tumor test. We use the tissue that, as I said, is the gold standard for testing. And then if we get DNA, we get sequencing, and the mutation is present, our recommendation is then at that point to check for germline to make sure that that mutation is just a somatic mutation and is not a germline mutation. Otherwise, that has an implication, of course, for the familial risk. And if the mutation is not present, then done. We will not recommend anything. We will not start a PARP inhibitor. In case the first test fails, so our recommendation is to go for again a red biopsy and reattempt for somatic tumor test using the new obtained tissue. If the biopsy is not possible or the rebiopsy fails, at that point we would recommend blood testing, so liquid biopsy, and because ctDNA at the moment is not widely available, the recommendation is to go for germline testing. So these are the recommendation from our GLH. So in conclusions, what I guess we have discussed today is that PARP inhibitors are definitely effective drug in metastatic castration prostate cancer with HRR alteration, but mainly with BRCA1 and BRCA2, and especially the HOMDEL seems to give the greatest clinical benefit in terms of PARP inhibitor sensitivity. However, we should identify early this alteration, and most likely what's going to happen in the future is that some of this testing will not be reserved just to the metastatic CRPC setting, so the setting of patients that have failed already on hormonal treatment, but we will be, we will be testing most likely patient at diagnosis, or at least at diagnosis of metastatic disease, a bit like happens basically for lung cancer, where we will have a report straight away with a BRCA1 or BRCA2 alteration. So I guess that's what's going to happen in the next future. And usually when I give a presentation, I end my presentation with a beautiful picture of Newcastle University in one of the sunny day that we have in Newcastle. But because you most likely know how Newcastle University looks like, I want to thank you with a picture of Naples. That is the city where I was born, and that's our golf. And I hope that you go and visit Naples because it's beautiful, actually.
Fantastic. Thank you so much, Pasquale. That was an absolutely fantastic presentation. I'm sure everybody will agree. So does anybody have any questions then?
I see probably something in the chat.
So I put in a link to, you mentioned about the ctDNA, so I just put in a link to Ali's talk that he did a couple of months ago for us on ctDNA. So if anybody wants to link into that, then that's just there. Whilst I'm also in the chat, I'm also just going to put Pasquale's LinkedIn profile. So just if you want to follow the fantastic work that he's doing, then that's there. Anybody else got any questions? Feel free just to raise your hand or just pop it in the chat. So Patrick's put a comment in. Do we have any feedback on the Galleria trial and prostate cancer?
Galihad, probably. It's written gallery, but it's probably Galihad trial.
Is that right, Patrick?
Isn't it?
I think it's the gallery trial that's being done at the moment with the blood test.
Okay, I'm not.
We found the limits of your prostate knowledge.
Oh, definitely. There are many of that, many, not just it.
I don't know, on that presentation, it was fantastic. I don't think so. It was brilliant. And from a topic that is confusing, I certainly kind of really understood that. It was fantastic. It was great. So any other questions from those on the floor? If not, I'd just like to ask a question. So as a genetic counsellor, with my genetic counselling hat on, how do patients respond? Do they easily grasp the idea that, difference between somatic and germline, or in cases where a germline one is identified, how have you found that experience of kind of, moving into that realm with patients?
So they are actually really pleased to hear that the majority of these alterations are just present in the tumor, because that put their mind at ease straight away. However, they are always worried about their children. I have to explain that, in case there is a germline alteration, I already start telling that not necessarily their kids will get a BRCA2 alteration. It's higher the likelihood to get this alteration if the father has this alteration, but doesn't mean necessarily that the sons or the daughter get these alterations straight away. And even if they have the alteration, doesn't mean necessarily that they will get a cancer the breast cancer or prostate cancer or pancreatic cancer. However, I stop there and then I say, usually I say that will be the geneticist that will explain these things in case we think there is a germline alteration. What is a really tough question to answer most of the time is that, I'm happy to have also your input in this. When there is a BRCA2 alteration that is identified in the family, of course there are follow-ups that the carrier that doesn't have the cancer can follow. So if the daughter of a prostate cancer patient with BRCA2 alteration is tested positive for a BRCA2 alteration, she can have, she can start a follow-up for breast cancer. And follow-up for breast cancer are now, in place. We know that they have to have ultrasound or mammography. So this is quite, a wide knowledge. But we don't know what a male, so what a son of a prostate cancer patient with a BRCA2, if test positive and is a carrier of BRCA2 alteration, what he has to do. So I went to search myself, and the only thing I could find was some recommendation from the NCCN guideline of testing, the PSA at least 10 years earlier than when the father was found with prostate cancer. However, personally, and I don't know what you think, but I think that's quite risky, because let's say that the patient, the first case in the family,
this is 70,
or even like 60,
yeah.
65, yes. So that means that 10 years earlier in your case, you're the son, means that we should test him like when he's 55, when the risk of having a high PSA just because you have prostatitis because you're an active man, it's quite high.
So whilst I'm on to comment into the workforce and education lead role, I'm out of my clinical GC role, but up until a year ago, and I don't think there's been any major changes, the recommendations are for BRCA2 men is that they discuss with their GP accessing screening from about the age of 40. So it's that's the earliest that we would really recommend it. But again, there is no firm guidance to that. Which maybe with kind of research like this that is coming to the fore, and as we are kind of understanding more, then it may well be that we kind of hope we hope that we get more firm guidance. But yeah, from 40 is the age of recommendation. And just to back up your comment about kind of where your conversations end and where genetics pick up, it's just to reassure people that very much the testing for these variants are very much a part of kind of diagnostic and treatment based testing, but where testing is for relatives on a predictive nature and discussions around whether they want testing or not, and that very much is kind of anchored within genetics, and that's what we've been doing for many decades. So please feel reassured that your local genetic service is there to reach out to, and within NEY we have Sheffield, Leeds and Newcastle clinical genetics service. For anybody joining from a national audience, then if you have a look on the BSGM website, they'll be able to tell you what your local service is. So thank you. Any other questions? No. Okay. Well, that's great. So, well, Pasquale's, as I say, has happily shared his LinkedIn, so feel free to reach out to Pasquale individually if you've got a question, or feel free to email ourselves.